Hey everybody, welcome back to the ECG channel. My name is Reed, and don't forget that you can download the PDF down in the description below that is linked so that you can follow along with this ECG and put that ECG in your vault for later. So don't forget to like this video and subscribe to the channel if you enjoy the content. Let's jump into this fun ECG. So the first thing we're going to do with every ECG is look at the forest, and the trees of the forest are my QRS complexes. And so maybe I'll start here in lead 2. You see we've got it starts off with this narrow rhythm, and then we've got this kind of wide, complex, early beat. And then you see we've got a little bit of what seems to be a pause, and then kind of resume what seems to be somewhat of a narrow, complex rhythm that speeds up, and then seems like kind of you get the same cycle all over again. We get a wide, complex beat, a little bit of a pause, and then what appears to be the resumption to a degree of our narrow, complex rhythm. Okay, and there's some nuances here that we're going to work through. We do see that if we look at these narrow complex rhythms, that we've got P waves that conduct to the QRS, P waves that conduct to the QRS, P to the QRS, right? What's interesting is that doesn't happen all the time. I don't necessarily see a P wave here, right? I don't see a P wave here either, so we'll talk a little bit about maybe what do we think's going on with this rhythm. We see that when we do have P waves, right, so let's kind of evaluate that atrial activity. When we do have P waves, if you look really closely up here in lead 1, you can see there's a P wave that's upright in lead 1. If you look in AVF, you can see those P waves are also upright in AVF. So it tells me that the P waves that are being generated are from the sinus node, right, because they're upright in my lateral leads, telling me that my P wave axis is going down and to the left, which is what we would expect with a sinus node in the top right kind of portion of the atria. So we have some sinus P waves. Well, what's going on with our AV node? What is our PR interval, and how does that kind of change throughout this rhythm? Well, when we do have P waves, I see that my PR interval, we'll go to V1 here. My PR interval, when we do have a P wave, my PR interval is maybe 4 little boxes, and so that's 160 milliseconds. We know that's normal, right? We know 160 is in between 120 and 200. And every time we have a P wave, right, every time we have a P wave, it seems to conduct to the QRS with that fashion, right, normal AV node conduction. And when I scan through to look for extra P waves that are kind of on the baseline of this ECG, I don't really see any extra P waves that don't have QRS complexes. So that's what we have. Let's take a look at the QRS morphology that is being generated here. We have QRS that is narrow, right? The width of my QRS is less than 120 milliseconds. My QRS axis seems to be upright in lead 1 and upright in AVF, telling me that my QRS is depolarizing down and to the left, which is normal. And you can see I've got good R wave progression, right? I look, I got my little R wave here in V1, it's growing in V2, and then you see it kind of gets smaller in V3. I can almost guarantee that has to do with just poor lead placement, and then it grows to be dominant in V4, V5, and V6. So everything about this QRS looks good. My QT interval also, I would say, is appropriate, right? You look at in between maybe these two narrow complex beats here, you can see my QRS definitely terminates by that midway point, okay? And so when we have these back-to-back sinus beats, I say it's good to see what is my intrinsic sinus rate, right? And so maybe I'll measure my sinus node, right? Here's a sinus P wave, here's a sinus P wave, so I can measure these QRSs. They seem to be at about 300, 150, 175. This would be 60, this is 50, so maybe 55 or so beats per minute. It doesn't have to be perfect. So we've got a sinus bradycardia at when the sinus node is going. We have a sinus bradycardia. And so now let's kind of work through, we scan through, I'll talk quickly, we look for pathological Q waves and ST and T wave changes. We don't see any, right? So no ischemia, no infarction, no previous kind of MI signs on this ECG. And so now you're probably like, well, let's figure out what's happening. And so let's look maybe here in lead 2 rhythm strip, and let's try to work through what we think is going on. So we've got a P wave that conducts to this QRS, and then we have this funky looking beat, right? It's early, so we have premature contraction. It's wide, right? So we know that it's not taking the highway His-Purkinje system that we like. It's very wide, right? Here's my interval. And so this could be a premature ventricular contraction, but we need to make sure it's not a premature atrial contraction that is conducted aberrantly. And so I look on the T wave and the ST segment before it, and I don't see any premature atrial contractions. I look at V1 because I know V1's got sharp P waves and flat T waves. I don't see any. So that confirms that this is a premature ventricular contraction, right? And you can see this one is the exact same morphology and premature ventricular contraction, right? I'll let you guys kind of go through your algorithm with that one, right? But the same thing, nice smooth T waves, right? No P waves in front of it. So we have that, and then we have this pause, right? So then we got to define, well, why is there a pause? Well, we've got a pause, and let's look at the QRS that occurs. You see we have a narrow complex QRS, but I don't see a P wave in front of it. So this is likely a junctional escape beat, right? It's narrow, so it's going down the highway system, that His-Purkinje system. So it probably has risen from the AV node and gone down our normal His-Purkinje system, right? Just like the normal QRSs are. You can actually see a little bit of a P wave hiding right there. I bet you that that junctional escape occurred just before that P wave could conduct to the QRS. So I think what is likely going on is we have this premature contraction that causes somewhat of like a compensatory pause. That compensatory pause could be for one or two reasons. It could be because maybe there's a P wave that's somewhere hidden in that T wave, right? And that P wave doesn't conduct because the PVC causes that P wave to be blocked because the premature ventricular contraction now has the ventricles all refractory. So it could be that. Or it could be that there was a retrograde P wave that we don't really see very well. Maybe this is a retrograde P wave. Maybe that little bump that you see there, that little bump is a retrograde P wave. It's really hard to tell here. You know, either way, it doesn't matter. There's a compensatory pause. Then you get a junctional escape beat. And then you see the sinus node takes back over. So then we have sinus beats, sinus beats, sinus beat, another premature ventricular contraction, another compensatory pause with another junctional escape. So why are we having junctional escapes? Well, we know the junctional escapes come from the AV node. We know that the AV junction has its own ability to fire off at 40 to 60 beats per minute, if not already stimulated by, say, the sinus node causing atrial depolarization, which is captured by the AV node, right? Because we know that resets the clock. And so if we have a pause that meets a certain amount of time, right? And so this pause we could actually measure. It's like 300, 150, 100, 75, 60, 50. This would be 43. So like that's a 45 beats per minute rate kind of interval there, which is just in line with what we said the junction would do. So this makes sense that we have junctional escapes, and then we have the sinus node as it's kind of stunning itself from this premature ventricular contraction potentially, just kind of catching back up. Then that's what we have. So put this all together, what do we have is we have a sinus bradycardia, right? We said our P to P intervals is a little bradycardic. We've got premature ventricular contractions leading to junctional escape rhythm with the resumption of our sinus rhythm, with this pattern occurring kind of intermittently. So I hope this helps. And if you have any questions about kind of the physiology and the pattern that we're seeing here, feel free to ask. It's really important that you understand cardiac physiology and how that's represented on the ECGs so that you can work through these problems. This is very common. These types of things are really common, but you're not going to be taught this in an academic setting, right? You have to reason through these ECGs, right? ECGs are meant to be reasoned through. So I hope this helps, and thanks so much for watching and supporting the channel. Subscribe if you enjoy, and we'll see you on the next ECG video. Have a great rest of your day.